Hello and good morning, good afternoon, good evening, everyone, wherever you are joining us from. It is a pleasure to be with you. Tista Chakravarty-Gannon, and I'm going to be talking with you today about thriving in the NHS. So hopefully you will be able to see my slides there. Perfect timing. What I want to say, first of all, is welcome. Whether you have started UK practice, are thinking of coming to the UK to join the NHS, or are supporting colleagues who are thinking of joining UK practice, welcome. It is so wonderful to have this opportunity to talk with you. As you'll see from the message on screen, please do share any questions and comments in the Slido tab as well, and we will try and get to them, but I can also communicate with you later around anything that we don't get covered today in the session. So first of all, by way of background about me before we get started, we'll explore the challenges, we'll explore the opportunities in UK practice. But to introduce myself a bit more thoroughly, I've been in and around the health service here in the UK for, well, it's 25 years now. And I started off working with survivors of abuse in what we call the SARCs here, Sexual Assault Referral Centres. So that's where I started, and I still do work to support survivors, but that tends to be about 1 day a week now, because just over 10 years ago, I was asked to join the GMC, that's our General Medical Council, to help set up a support service for doctors on the ground. And I remember at the time I was really interested in doing that because I'd started to get involved already with some systems work, because working in sexual assault services, it became really clear to me that when systems don't speak with each other, when there isn't enough support for colleagues on the ground, then our patients can fall through the gaps. So that systems leadership was really important to me. And I jumped at the chance to join the GMC, the General Medical Council, to provide that support to doctors on the ground. And at the time, of course, I didn't know a huge amount about the GMC. And at one of my first conferences, when I was fact finding around what doctors really needed and wanted from the GMC, I remember I was introduced onto the conference stage to the theme of the Imperial March, Darth Vader's theme tune, for those that don't know. And I remember thinking at the time, certainly, whilst the organisers were joking, it crystallised for me just what fear we can be beheld in by the profession at times, because we are thought of predominantly in fitness to practice terms. We are the regulator, so we are often thought of that way. But as I learned more about what we do at the GMC, and these are all our statutory functions that you can see on this slide here, it became really clear to me that standards there at the centre, that's the absolute fulcrum of what we do. And supporting doctors to deliver what are challenging ethical standards in what is increasingly a challenging environment, that is logically, but most importantly, morally, absolutely the most important thing we can do. And it informs all areas of our work, whether it's education, revalidation, registration, or fitness to practice. And I would argue that in many regards, providing that support is much more important for patient safety than our function on fitness to practice, which of course is important, but the really serious fitness to practice issues we see apply to such a tiny minority, hence the need to provide support around good practice. So that is a little bit about my background and why I got involved in the GMC and some of what I learned in those early days. But what that all resulted in was formulating GMC Outreach. And that's a team that I now head up with a couple of other colleagues as co-leads. And I'll let you digest this slide in a minute and the bullets on there. But yes, we are out on the ground wherever you are based. In the UK, we have liaison advisors there, outreach advisors to support you. And I'll just let you read what that says. So that is a brief summary of our work, but every day we are there with doctor groups, whether that's in hospitals or whether that's membership organisations, and we're also working with those organisations at leadership level to understand what's needed and then provide local supportive teaching interventions. But then, as per the final bullet, it's also really important that we're hearing what's happening in reality on the ground. And that means that we can take action. So a junior doctor might tell me that they are really struggling over the weekends. Last weekend, they were looking after 47 outlier patients in T&O, in trauma and orthopedics. Can we help? Yes. They might tell me that they want to get involved in the review of our good medical practice, our core medical ethics guidance. Yes. So there are a variety of ways that we go out with proactive work, but then also hear what's happening and provide support as needed. And here's our team doing just that. And most of our work is rooted in our ethical standards, but also anything else that might be relevant, that might be useful to hear about from the GMC. We'll be out there delivering workshops and exploratory sessions on it. So that's a little bit about outreach. But moving on to what we're specifically here to talk about today, I want to ask you, what concerns do you have about starting UK practice, or what do you think your colleagues might be worried about if you're facilitating journeys into UK practice? If you pop onto the Slido and just start sharing your thoughts. Let's see. So nothing coming in just yet, but I'll give it a few more moments. Any worries about starting UK practice? You can see someone's typing away. And I'll also share some of what we hear about as well, of course. But it'd be great to have your thoughts. Okay. So we either have no concerns, which is great, or it's just taking a little bit of time. But I can see someone is typing, so we'll just stay on this view for another moment. And yeah, getting accustomed to the system. Absolutely. This is, the primary worry that we see, and just conscious of time. So we'll move back to the slides and I'll share what else we hear. But thank you for that. Getting accustomed to the service. And this is huge, isn't it? It's wildly, wildly different. Going to any new country to practice medicine, there are going to be significant differences. And I'm sharing a list with you now. So just have a look at that and have a think. What do you think this list represents? And again, you should be able to respond in Slido. So you should be able to type in an answer there. So any ideas? What do we think that list represents? I'll leave that on there just for another few moments before switching to Slido so you can digest it and have a think of what it might be. Okay, so let's have a look. I can see that there are lots of good thoughts coming through. Do pop them into Slido as well, and I can see a few people are typing away there, which is great. Hospital policies, health and safety, safeguarding. Yeah. Right. Oh, not being harmful. Okay, interesting. And comments in the chat as well. Safety. Okay, let's go back to that slide. Training requirements. I'm glad I spotted that one just before we flip back, because, yeah, this slide, this list is a real list, and it is a list of the e-learning that one of my friends who qualified in Sudan, as it happens, and she started practicing here. This was the e-learning, the StatMan training, as we call it here, statutory mandatory training, that she was asked to do, and then she was thrown on to the wards, which is unacceptable. These are important things. Yes, of course they are. But we've just talked about our concerns about starting UK practice, the difference in the system. And just to expand on that now, it's not merely a different organisation. It is a different country with different cultural norms, different patient expectations. How do you sort out bank accounts? Which schools do you send your children to? How, how cold is it? Which is a serious point I'll come back to. And that information, that pastoral support, that help around culture shock, where is that in this list? So with all that in mind, I'm just going to share with you some feedback that we have heard from international doctors over the years. So as part of my work, I head a program called Welcome to UK Practice that I run for the GMC. And as part of that, we always work with international colleagues to understand what the barriers are, understand what the enablers are. And this is some of the feedback that's come from those focus groups. So again, I'll shut up and just let you digest these experiences. So these experiences, they're all really poignant. They're sad. And they're downright disgraceful, frankly. I'm going to the penultimate point now, where we have a colleague talking about the catheter. And in UK practice, there are male and female catheters. In his country of qualification, there's one type of catheter, unisex catheter. How is he to know that there are different types here if he's not been inducted and supported in that way? And as it happens, he was working on a male ward and was asked to go to that cupboard, but that cupboard had both male and female catheters. He picked up a female catheter because he wasn't to know any different. And that catastrophe for the patient and for him was eminently avoidable with proper supportive induction. And that is what is lacking in some places. But we'll talk about the support available, because I don't want to scare you, but I want to prepare you so that you know what the true picture is and what is available to support you. So this is from some research that we did. And the research, we knew all of this anecdotally, but the research gives us that evidence base to demonstrate that more needs to be done by the system. And it's some of the themes that we've talked about, the induction into the culture and language as well. That's important, because you can be the most proficient person in English, and then you can go to a corner of the country and hear lots of dialects that, you know, even I won't be familiar with. And then the language of the NHS itself, as it says here, is quite something. Many acronyms, you know. And then support with things like visas, living and financial arrangements. So there is a lot that needs to happen so that we can properly help colleagues who bring so much in terms of their compassion, in terms of their clinical skills, bring so much here. We need to give that compassion back. There are other challenges in UK practice as well, besides overcoming the whole moving to a different country with a different system. And these are two reports that I recommend everyone is aware of, but to just highlight a couple of the things from them. The first one is around fair referrals, and this is around complaints. And a challenge that we see around complaints is that some groups of doctors do not receive the support that we would like across the board. Now, in some places, the support is brilliant. In many places, actually, but in some places, it's really not. So we've already talked about inadequate support into new environments and potential isolation, lack of early feedback. Some doctors are treated as outsiders. These are real issues. And then more broadly, many in the NHS experience well-being challenges. And our report on caring for doctors, caring for patients demonstrated a need for giving doctors more autonomy and control, giving doctors more of a sense of belonging through culture, change in culture and leadership and team working, and allowing doctors to feel competent, because you may be eminently competent, but if workload pressures don't let you deploy that competence, then, well, it's very difficult and you start to question yourself. So this report really demonstrated the need for this to be clear and implemented everywhere. And there was it includes some brilliant case studies of the places that are really getting this right, that provide all of that for their colleagues. And this is something that we really, really want to spread across the system. But if you are coming to practice here, it is worth being aware of this, so you know the standards you should expect and you should be being provided by your employer. And as I say, we are there as an outreach team to help if there are challenges with that. But reflecting on the workload piece a moment, because of course it's likely you'll hear a lot about this. For many years now, and I'm talking pre-pandemic as well, we have heard about how workload feels like a Sisyphean task, just constantly rolling that boulder up a steep hill. And to just reflect on that in a slightly tangential way for a moment, I'm going to share a slide with you. And I want you to find the mistake on the slide. And I'm only going to give you a short period of time. So look at that slide. So what do you think the mistake is? And I'll give you 10 seconds and then we'll switch to the Slido. Right, let's switch to the Slido and let's see if anyone has identified the mistake. Let's see. Brilliant! Someone has it straight away. There are some comments which there's no zero colours, but the person in Slido there has spotted it. And if we go back to this, slide, I'll run through it with you. I'll just switch back. And as our colleague identified, it's two the's. Can you find the mistake? And of course, the slide is designed to hoodwink you. You've got different text sizes, font sizes, different colors. As our colleague said, there's no zero. There are all kinds of things going on there that are designed to trip you up. And I only gave you a short period of time. And when you do this in a room with people virtually or in person, you tend to see about half people get it straight away, half people don't, and then get really frustrated when it's pointed out to them. And my slightly tangential take, bearing in mind we were talking about workload, is that this is somewhat analogous to working in a high-pressured system. So when you are constantly doing and doing and doing, it can be easy to miss small things in that pressurized environment. And sometimes I hear feedback from system leaders to say, but we're under pressure, so service delivery is the most important thing. So we've got to do and do and do. And I understand that. But if you don't have the space to think and you're constantly on a hamster wheel of doing and doing, then you will burn out. There are many, many risks to that. You will burn out. There's your own well-being here. Patient safety as well. If you're on that wheel, as I say, then patient safety is really affected. So we are strong advocates of having that time and space to think, time to reflect, time to learn, and that is clear in our standards and guidance. So on that note, because the animation is the animation doesn't work quite on this system, so I'm going to read out this question to you, and the question is, you might be able to see the answer if you can read through the text. So I'm just going to give you a question verbally, and tell me what you think. So the question is, what on an ICU over 22 days, a study was done. And over those 22 days, what characteristics or presentation do you think were most associated with oliguria or dehydration? So an intensive care unit over 22 days, a study of dehydration. What characteristics and presentation was most associated with dehydration? So have a think about that and then type your answers into the Slido. So we can switch to the Slido because we can't quite see the question. Give you a few moments to think about that, bearing in mind it's an intensive care unit. And it was just under a month. And I can see a couple of people are typing away. Low, yeah. And so someone said low urine output. And you might be thinking that the phrasing of this question is a little peculiar. Characteristics or presentation. And you'd be right that the phrasing is slightly peculiar, because I'll go back to my slide now. So what it actually is, the characteristic most associated with having dehydration was being a junior doctor. So the junior doctors had more dehydration than the patients in this intensive care unit. And this is, it speaks to the workload issue. And it is incredibly, incredibly important that we look after ourselves. And it's a big, big focus. Well-being is a massive focus now in the NHS. And this was pre-pandemic. So turning to what we learnt in the pandemic, another question for you. What percentage of doctors do you think reported that during that pandemic peak, that first peak, what percentage said that that had a negative impact on their mental health and well-being. So you should be able to see the multiple choice questions on your Slido now. And if you can take a vote on that Slido, and let's see if any responses come in. Okay, so at the moment, 62% is winning, but a third of you are saying 45%. Okay, great. If we can go back to the slides and I'll share the result with you. So it was 32% based on the research, the survey, that we did. However, there was a survey at the same time done by the BMA, so the British Medical Association, and it came out as 45%. So either way, far too high. If it had been 23%, it'd be too high. But it's understandable. We were in that pandemic peak. What can we do about that, though? Because when, as we were saying with well-being, when you feel under that level of pressure that it impacts your well-being, when you feel that you can't be competent in the work that you are competent at otherwise, then it leads to something that we call moral injury. It's a term you may have heard of. And some of the work that we've been doing with partners, ourselves, since we started hearing about all of this moral injury that colleagues were subject to, is around really focusing on support for well-being. And I'm just going to share an exercise with you. And that exercise, we'd normally see it at all the 4 quadrants pop up separately, but I'm just going to start in the bottom right. A good way to look at your state of well-being, I guess, is thinking about what your core values are at work. And I did one myself. So these are my core values at work. So this is when I'm in the service working with survivors. So these are my core values. And as I say, it's good to do this as an exercise where you just get a bit of paper and jot it down. What are my core values? And then move on to the next question. So what are you thinking and feeling when the context doesn't allow you to meet your core values? And that happened with me. We started to see, we already work in a challenging service, of course, but we started to see significant increase of domestic violence, domestic abuse. And in that context, I found that I was increasingly stressed. I was increasingly worried about how I'll help people with all of this coming in. And of course, our service resources were down because people were off with COVID a lot. I was feeling very negative. I was tired and I was disengaged. Of course, I still wanted to help people, but with the wider service, I felt very disengaged. So moving on to the next question. What are you doing and what are you doing? So we've talked about what we're thinking and feeling, but what are we doing when working at odds with our values? Well, for me personally, I was thinking and feeling all of those things, and that meant what I was doing was rushing. My communication slipped. Wasn't nearly as effective as I'd like it to be. And I was deprioritizing areas where I knew I could make a difference, but I was just pushing them out to the peripheries of my mind. And interestingly, as it got busier, I was switching off less. So it's normally busy, but I have decompress time, which allows me to re-energize. But I was switching off a lot less. I was thinking about it. I was taking work home a lot more than I normally do, even if it was just mentally, not necessarily doing the work, but thinking about it psychologically. So then finally, what are you doing when you are working in line with your values, actually? So when things are much better, that's when I personally am much more creative. That's when I get involved in quality improvement. That's what I mean by QI there, sorry. And that's when I'm supporting my colleagues more. And this exercise and then reflecting with a trusted colleague, a group of colleagues, this can really help to something that lead to something that we call moral growth. And these kinds, it's just one intervention, but these kinds of interventions have been really important in this extremely challenging period to help us move from that moral injury we feel into a place of moral growth. So there is a huge amount going on around well-being, and when we're in that place of working to our values, we are much less likely to need, more significant help that you will need if you fall into that burnout space. So that focus on well-being is absolutely imperative for us. Okay. And as I say, that's a really important area for all of us. But just to talk about the GMC for a moment, it's something we've been speaking about pre-pandemic, and we had a program called Supporting Professions, Supporting a Profession Under Pressure, which looked at a number of these areas. And that's what gave birth to those two reports that I shared with you around fair referral and around caring for doctors, caring for patients. And we really want the NHS organisations we work with to implement it everywhere. But there is a lot of support available to you. And let's just look at some of that now. So we've talked about some of the negatives because I think it's really important to be aware of the true picture. And the true picture also includes a lot of really good work that goes on, and be armed with that information because it will really help you in your journey for UK practice. So there are myriad organisations that can help. These are just a few. So sometimes it can be challenging speaking up, raising concerns. So there is a National Guardian Service, and in England there is similar services in Scotland, Northern Ireland and Wales, but England has started with this formal National Guardian Service rollout. And wherever you work in England, there is there is a Freedom to Speak Up Guardian. There are initiatives like Headspace. So 2 international medical graduates came here. They found that they lacked the support, just as I was talking about earlier. So they set up their own induction. And it is a great program. I've spoken there previously. And then there are organisations such as defence organisations, membership organisations, colleges. There's all sorts of organisations that have resources and can help you. And there are diaspora organisations as well. The NHS itself has lots and lots of support. As I say, this is an important area, not just for the GMC, but for the NHS. And yes, I've talked about how some places don't get it right, but centrally, this is an important agenda for the NHS, looking after its people. And in fact, there's a programme called that under the People Plan. So there are loads of resources available from the NHS itself and from us. So on our website, you've got access to learning materials. Please do take a look at those. But also our standards and guidance. We have a wealth of standards and guidance, and sometimes we get the feedback, well, isn't some of that common sense? And some of it may be seen that way, but this horrible slide, don't attempt to read everything on it. That's the point of this slide. This slide is a representation of every single piece of legislation that we distill to put into just one of those pieces of guidance. In this case, it's the where we go, the confidentiality guidance. So that booklet there accounts for all that legislation. It looks at as well the wider ethical framework, and it puts it into a more digestible document for you. And that means that those standards are not just common sense. They are a benchmark for your practice. They are your safety net. So when you've got a really complex dilemma, and I'm going to share one with you just as an example later, it's your safety net for that decision making. It's safety net to you, it's safety net to your patient. And it's your lever for change. So right at the start, I was talking about how we work with doctors on the ground frequently. And I'll always remember a group of my foundation doctors. They'd been told by a service manager that they couldn't get involved in the redesign of a new special care baby unit. They had some thoughts, they had some views, and they were told, no, this isn't your job. But actually, our standards say that you need to be allowed to be involved in quality improvement. So they were able to use our standards as that lever for change. And as it happens, they stayed with the project redesign throughout Foundation Year 1 and to the end of Foundation Year 2. So that was a brilliant success. Other resources that we can support you with. I mentioned briefly our Welcome to UK Practice course. So this is something that, as I said, I lead. And my team developed Welcome to UK Practice as a course because we know that people needed that welcoming start in UK practice, and the system didn't provide anything. That is changing. I'll come to that. But as it stands, or as it stood at the time, we could see that there was nothing in the system, so we created our own. And of course, it only covers GMC areas and a bit of an introduction to the NHS. It's not the full comprehensive support that an employer should provide, but it is very, very important. It's free. It's a half day, delivered by an expert team. A team expert in GMC guidance, in culture shock, the support available to you. There are other tools and resources that support it. And it looks at really complex ethical areas. So we're not going to go through this now, but I'll share this as an example with you. And Talia here is a composite of many of the clients, patients that I see in SARC. And I'll just let you read that. So you start working here and Talia presents, and this is the situation. What do you do? What do you do about her not wanting to go to the police about the domestic abuse that she's subject to? What do you do about the fact that she doesn't want her GP to know about her HIV status? What do you do about the fact that she doesn't want her partner to know about her HIV status? Now, there are all kinds of considerations here. And I defy anyone to say that this is a common sense scenario. And this is the kind of thing that our standards help you with. How to support Talia, but how to think of that wider public interest as well. It guides you through what to do. And in our Welcome to UK Practice course, these are the kinds of things that we look at and explore with you through a workshop. And I can't recommend it strongly enough. So please do access Welcome to UK Practice if you're thinking of coming here. And just as a question around that, after attending Welcome to UK Practice, what percentage of doctors do you think said that they would change their practice after attending? So have a look at the Slido again, and this should be, I think, your last multiple choice question, your last question on there. So go into the Slido and let me know how many do you think change their practice. Just whilst you're typing in there, I'm taking a vote. We're talking about dehydration before, so I'm going to take a drink. Any thoughts? Okay, 75%. Give it a few more moments. Gives me a chance to have a bit more of a drink. Okay, let's switch back. We've got 75% there as the vote. And I'm actually delighted to say that the answer is 91% would change their practice. And this is from those feedback forms, those evaluation forms that, you get at the end of a course. But there is academically robust evidence around this, because we asked a university to do some research for us. And they found that, highly unusually, for a medical education intervention that's a one-off intervention, at time 2 follow-up, people had actually changed their practice. That's extremely unusual. And the accolades that we hear about the value people get from Welcome to UK Practice, the opportunity to network and link with colleagues that sometimes they stay friends, throughout their journey in UK practice. So it makes a real difference. As I said earlier, it's only part of the picture, and we're currently working with the Medical Workforce Race Equality Standard to provide a much more comprehensive induction, because we can do what we can do at the GMC, other organisations can do similar. But when you are in a trust in Liverpool, Newcastle, wherever it may be, you need to understand how things work locally. The things we were talking about before, which areas are good, which schools are good, who are my friends, who's my network locally, how do things work in this hospital or this GP practice, primary care network, whatever it might be. So that is something that is being developed now, and the launch, in fact, has been developed. The launch is actually on Monday, and we are hopeful that every employer will afford their international graduates with this proper, inclusive welcome and ongoing support. So that is on the horizon as well, which is brilliant. And then finally, as we wrap up, I just want to share this with you, and I'll get a way of sharing the link with you. There's a brilliant video. Clearly I'm biased, but there's a brilliant video that you can watch called Things I Wish I'd Known, and colleagues who've been on the Welcome to UK Practice course filmed it for us to just share things that they wish that they had known when they started UK Practice. And it's a wonderful, positive video, just under 10 minutes, that shares some top tips, if you will, from them, and gives you a flavour into that journey. So I'll get that link shared in the chat with you. In fact, I think I'll arrange for that to be shared. But yes, that is pretty much it. To wrap up, have a think about what you'll take away today. I guess my call to action is be aware of the challenges, but then also be aware of the opportunities, because there are brilliant opportunities here. And knowing what support you are what support is available and that you have a right to really helps, and all of that will smooth your journey into UK practice. But thank you so much for your interest. I hope that's been helpful.